for inviting me to this program. We have signed a memorandum of understanding this morning. My team came over, I was busy elsewhere. And our intention as a reproductive physician is to prevent cerebral palsy. I've been sitting and hearing to all the talk of problems starting from Arijit Chattopadhyay till our good friend Shoikat Sengupta, and really appreciate all the efforts. And my good friend Gautam Mitra has done a wonderful job bringing all the disciplines together. Now, today I'm going to briefly say about what we do as a reproductive physician when people are coming to us for getting pregnant. And as evidence has suggested that perhaps our overzealous treatment is resulting in many cases of multiple pregnancy, premature delivery, and maybe we are partly responsible for some of these cases of cerebral palsy. And very briefly, I would like to say what we can do as an obstetrician and reduce the risk of cerebral palsy. How life begins? Life begins within the fallopian tube when a sperm and egg meet. Now, artificially, we can also make eggs and sperm meet in those cases who are having difficulty like tubal obstruction, endometriosis, male infertility, etc. And basically what we're doing, we are stimulating the ovaries to produce several eggs, and we are getting multiple embryos, and we are transferring perhaps 2 or 3 embryos for a better success rate, and this is resulting in increased incidence of twin pregnancy and higher order multiple pregnancy. But why we are doing it? Because we need to give success. When IVF started nearly 35 years back, then everybody wanted good success without forgetting that the success rate of natural conception is only 30%. Now, to start with, IVF was giving a success rate of 5 or 10%. So in order to multiply the success rate, everybody thought of transferring multiple embryos. Now, over the period of years, we fertility specialists have realized that we have actually created some problem. Although these women are getting pregnant, many of them have very high risk during their pregnancy, so we are increasing maternal risk, and we are also responsible for poor perinatal outcome. And sometimes these patients who have multiple pregnancy, we are selectively doing a reduction of the pregnancy, and that is also associated with high risk. So with multiple pregnancy, the preterm birth is nearly 5 times more common. Low birth weight baby, again, nearly 5 times more. Perinatal mortality is almost double, and the incidence of cerebral palsy is also higher, almost 1.5 times. Many of these kids who are born after assisted conception, they have developmental delay. And many of these problems are associated in women who have uterine malformation, they have a small uterus, cervical incompetence, or previous history of premature delivery. Now, International Registry on IVF Children, published in the year 2003, suggested that there's a higher risk of birth defect after assisted conception. So there was a big debate, then whether we should go ahead with assisted conception or not. Now, when you analyze these patients, then we identify that it is not the IVF, but the problem which is resulting in the need for IVF, or the age, or the medical associated problem of these women who are having IVF is actually responsible for this higher incidence of birth defect or perinatal poor outcome. Therefore, IVF actually is not responsible, but multiple pregnancy, and many of these women, they are elderly, they are obese, they are hypertensive, diabetic, they have poor egg and sperm quality. So what are the implications? With multiple pregnancy, we are having a significant increase in healthcare costs, severe stress experienced by these patients, and even after the delivery, the parents are really worried because some of them will have to continue with lifelong support needed for disabled children. So there's a raving criticism questioning the justification of entrusting the responsibility of our children's health in the hand of those involved in ART therapy like myself. So we are questioning what we are doing, whether it's right or wrong. Now, I thought this is a very appropriate session to explain how we have changed over the period of years to avoid this problem. We have learned that if we transfer only one embryo, we get a success rate of 20%. If we transfer 2 embryos, success rate is 30%. But if you have 2 embryos and then you choose one amongst those 2, which we call elective single embryo transfer, your success rate is again 30%. So even by transferring one embryo, if we can choose, if we have multiple embryos, and if we can choose and select one which is best, we will be able to give them higher success rate, but still not have the risk of multiple pregnancy. And this is a very interesting study which basically suggested if you transfer a single embryo, success rate 30%, double embryo 47 or 50%. Now if you transfer one fresh and one frozen, your success rate is same. So if you have many embryos, we don't need to transfer all of them together. We can transfer one. If she is not pregnant in the subsequent cycle, we have the frozen embryos we can transfer. So cumulative pregnancy rate is all the same. But if we transfer many embryos together, then the risk of multiple pregnancy is nearly 40%. So the conclusion we have made that we will stimulate less, we'll have less number of embryos, and we will transfer perhaps one at a time. The best embryo goes first, and the next best second, and like that. Now, we will have to do it in those centers who have a reasonably good pregnancy rate, they have a higher incidence of multiple pregnancy, and they have an efficient cryopreservation program. Now we have a machine called Embryoscope. So we can actually put all the embryos, and the computer will look at all these embryos, put individually, take pictures every half an hour, analyze the data after 24, 48, 36, and 72 hours to let us know which one is the best embryo. And we take several criteria like how many blastomeres are there, what is the rate of cleavage, whether they're multinucleated or not, how much rate of fragmentation, and things like that. And if you have a frozen embryo, whether the embryo is intact after thawing or not. So in summary, selective embryo transfer gives us a very good success rate or pregnancy rate without, giving the risk of multiple pregnancy. So that is the way forward. It is equally effective like the previous technique we used to use, but it is substantially cheaper because we are using less medicine to stimulate these women, and when these women are pregnant, they are having less complication during pregnancy, less perinatal morbidity or mortality. So eventually, lesser number of women would require, advanced treatment, and less babies will go to neonatal intensive care unit. So we recommend selective embryo transfer, and we are proud to say that we are one of the foremost centers in this country to start this. Over the period of last 6 months, we had fantastic result, and from April this year, we have taken the pledge that in no woman we are going to transfer. Before, what we used to do, we used to transfer maybe single embryo in less high-risk patients, and patients who have poor prognosis, lower chance of success, we used to transfer 1 or 2. But even in many of these women, we were having multiple pregnancy. Our multiple pregnancy rate to start with 7 years back was about 40%. We reduced down to 20%. Even this year, we had about 10%. And our future is to bring down to multiple pregnancy rate to 0%. With single embryo transfer, we can substantially reduce maternal risk. We will have significant improvement in perinatal outcome. And by that way, we can indirectly reduce the incidence of problems like cerebral palsy and other related problems. But proper selection of cases is mandatory, and embryo quality assessment is very important. It's not an individual who is going to decide. It has to be done in an objective way by using things like Embryoscope. And we are having some non-invasive technique called embryonics. Well, we will collect some fluid from the embryo where the embryo is growing, and it's called proteomics if we assess the protein, and like that many other tests which will be coming very soon. We will have to think about cumulative success rate. So one message, if I could leave here to all these multidisciplinary specialists here, I know many of you won't be dealing with this patient, but what we can tell to any of your friends, relatives or neighbors who will be having assisted conception treatment, that they should realize that this is one of the area of medicine where we cannot give success on the first go. This is not having like an appendix removed or having the typhoid treatment with antibiotic. This is an area where the natural conception rate is 30%, and we can only achieve 30 to 40% pregnancy rate. But having said that, if they are not pregnant on the first go, they can try second, third, and fourth time. Of course, there is a question of economics, the cost, and that we are looking at. So we are planning to charge the patient per egg retrieval, not per egg embryo transfer. So it's like cumulative pregnancy rate and cumulative payment for maybe 3 cycles or 6 cycles together. So with this health economic, we are going to get fantastic improvement. Now the future of ART is with pre-implantation genetic diagnosis, which can reduce further the incidence of cerebral palsy and other related problems. Because what we can do, we can actually test the embryo before transferring it back inside the uterus. It will improve the pregnancy rate because we can detect those embryos where there is trisomy or any other chromosomal abnormality, and they will eventually result in poor implantation and increased miscarriage. So we can detect that. It will result in complete elimination of genetic disease, chromosomal illness, problems like thalassemia, problems like cystic fibrosis, Duchenne muscular dystrophy, because we have gene probes which can actually identify these problems in the embryo. As you all know, embryo has an outer cell mass and inner mass. Outer cell mass develops the placenta. So if we take 1 or 2 cells from the outer cell mass and test them by gene probe, or even we can do metabolic tests to identify those babies who are likely to have genetic illness or metabolic disorders and prevent transferring those embryos. So that will reduce or eliminate completely the possibility of termination of pregnancy, which is often done now after detecting the problem in early pregnancy. It will reduce the incidence of miscarriage, and it will avoid the need of termination of pregnancy. Now, I myself is not an obstetrician. My friend Dr. K.K. Roy was here this morning. I didn't hear his lecture. I don't know what he covered. Now, as an obstetrician, I think we have different antenatal tests and intrapartum fetal monitoring. So I'll just cover a little bit about it. So if we are very careful about the tests, now what happens is in a straightforward pregnancy, often the clinicians and also the patients feel pregnancy is a normal event. So as soon as you ask them to do some tests, they feel the doctor has some vested interest or the hospital has some special interest of putting these patients through investigations. But believe me, cerebral palsy and other perinatal poor outcome often happens to low-risk women. So of course in high-risk women we'll take special care. But there is no harm in doing screening tests to all women coming for pregnancy nowadays. Because gone are those days when women would have 6, 8, 10 or even 16 children, so 1 or 2 of them have cerebral palsy or perinatal mortality, doesn't matter. Now most people will have 1 or 2 and nobody is going to forgive you if there is a problem, because people often come to me and say, "Doctor, we have come to you. If you cannot detect the problem, who else?" Now, this question may have to be answered by all clinicians who are dealing with this problem. So we can do many tests nowadays, like an NT scan, nuchal translucency scan, between 11 to 13 weeks, we can detect Down syndrome. Blood test for double marker, around 12 weeks. Blood test for quadruple marker, where neural tube defect and chromosomal abnormalities like Down syndrome, Edwards syndrome, Patau syndrome can be detected. If we are suspicious, with this screening test, we do amniocentesis for final diagnosis, where we collect a little bit of amniotic fluid and do the chromosomal analysis. Detailed anatomy scan, now we have a very good ultrasound machine, which can pick up some of these problems between 18 to 20 weeks. We can do fetal echocardiography. Now, many of these pediatric problem is associated with cardiac anomaly. So this is an important marker. So if we can detect the cardiac anomaly early, then we can be suspicious. Now there is a fallacy. Indian government or Indian law says termination of pregnancy can be done only up to 20 weeks. So the question is, what happens if you detect the problem at 24 weeks? You cannot theoretically terminate. So that's why we, the obstetrician and gynecologists, requested the government to extend the duration of, extend the time of abortion up to 24 weeks. This bill was placed in in November in the parliament, but after debate they decided not to pass it. I think the main question is this issue of pro-life group suggesting that terminating at the 24 weeks is actually killing someone. But, viability, the definition of viability is after 24 weeks. So even if you deliver a baby at 23 weeks, that baby is not going to survive. So therefore, we need to discuss on this issue further. We can do growth scan and Doppler study from 28 weeks to 36 weeks, almost at alternate weeks, and identify where there's a growth defect, where there's poor perfusion of blood from mother to the baby. And as you all know, that we cannot identify all reasons for cerebral palsy in each and every case. But we know if there is problem with perfusion during pregnancy, the blood flow, then obviously that causes cerebral ischemia. So if we can prevent that during pregnancy or during labor, that will definitely prevent many cases. Now finally, during labor, we have cardiotocography. We can measure the fetal heart, we can monitor the fetal heart, we can measure the uterine contraction, fetal scalp blood sampling to diagnose acidosis quite early, partogram to detect non-progress of labor, because if there is a prolonged labor, that leads to fetal hypoxia. Now this question of delivering babies earlier, this is often a big issue convincing the patient. The duration of pregnancy is 40 weeks. Now, many studies are coming suggesting that ideally we should deliver the babies between 36 to 38 weeks, because the onset of labor is caused by fetal hypoxia. So fetal hypoxia, when fetus is not getting enough oxygen, that sends a signal for release of prostaglandin, so the baby is coming out. So my understanding is none of us work until the last day of our life. We retire. So if the longevity is 80, we retire at the age of 60. And there's a very interesting study done on obstetricians in UK. Those obstetricians who are retiring at the age of 55, they live up to the age of 80. Those who are retiring at the age of 60, they are living up to the age of 70. And those who are retiring at the age of 65, they die at the age of 67. So longer you work, take the stress of obstetrics, intensive care unit, anesthesiology, shorter will be your life. And similarly, why put the baby on stress for a longer period? At 34 weeks, we are getting maturity. You wait up to 36 weeks. In high-risk cases, deliver the babies at 36 weeks. And even in low-risk cases, deliver the babies at 38 weeks if they want normal delivery, induction of labor, if not, an elective cesarean section. And having said all this delivery, we need to do emergency cesarean section early rather than too late. And finally, deliver all our babies in centers with good special care baby unit and neonatal intensive care unit. I know this is a dream, this is impossible in a country like India, but unless we know what to do, how can we plan? So ladies and gentlemen, thank you very much for your patient hearing. We would like to see a happy woman like this, with a single baby, not multiple babies, with a single healthy baby who will grow, normally, have all the milestones achieved at the right time, and that is our goal. Hope in long term we will be able to achieve it. Thank you.
Study has been, I was wondering if any study has been done to see the, say, the IVF babies, how do they sort of function as parents, or when they mature, do they require again IVF?
No.
Do they have problems of, defective children and things like that?
No, thank you very much for asking this very interesting question. We continue to face this regularly in the clinic. First IVF baby was born in 1978, Louise Brown, and she has already delivered 2 boys, and that's natural conception and normal delivery. And since then, most of the IVF babies have been followed through because the National Registry continue this. But it's only with the male infertility. With female infertility, there is no problem with the children born. But with male infertility, what we find is we do this special technique called ICSI, intracytoplasmic sperm injection. And some women with Y chromosome deletion and other problem where they have male infertility, perhaps nature decided that they shouldn't have their own children. But now these children who are born after ICSI, of these men who have had chromosomal abnormality of the Y chromosome, they again have the same problem. They are more likely to have the same problem during their pregnancy. But basically, answering to this issue is like that, those who are thalassemia carriers, who are not affected, thalassemia carriers, they are quite happy to have a child with thalassemia carrier because their life is same, just like any other healthy woman, healthy man or woman. It's only thalassemia affected, they have a morbid life. So basically, we take the consent, and the answer comes from them. If I can have ICSI treatment and have a child, perhaps my son can also go ahead and do it. Now, there's an ethical question whether you should go ahead and do it, but if the patient's consent, then we definitely do it. But with any other female infertility, the incidence of birth defect, incidence of future fertility problem is exactly same. It is only we are treating a different population. We are treating more elderly people, we are treating people with medical illness and perhaps with other problem. That is why the birth defect and other problems are slightly higher. So if we take that confounding variable away, then the risk is same.
I'm sure that you all have enjoyed the excellent deliberation of Dr. Gautam Khastgir, who is one of the brightest stars in the galaxy of obstetrician. And I'm very pleased to tell you that we are from the same school and same college.
Thank you so much.
The next